He's also the clinical associate professor in the Graduate School of Public Health Programs at Howard University. And he's going to talk to us on bridging the gap in medication access and utilization to improve the quality of life and life expectancy in Africa through the lens of pharmacoepidemiological intervention. So I'm sure we all have Henry's bio, but I'll just briefly introduce him to our faculty, to our department this day. So in short, Henry is a graduate of Howard University in Washington, where he did his doctorate in pharmaceutical care, and then came to South Africa at Medunsa as a postdoctoral fellow. And he spent over 30 years of his career in medicine regulation with a focus in pharmaceutical care. He has been an associate professor here at Stellenbosch, supporting the training of HIV management with the Africa Center for HIV and AIDS. And his career really spans many, many years with Howard University in the US and South Africa here in Medunsa and Monash, South Africa, where he supported the development of the HIV AIDS management program, as well as the public health program at Medunsa, which is now Sefako Makato University. And in the years 2023-24, he worked with NEPAD and AUDA in development of a minimum package for regulatory for the implementation of African medicines, and several other agencies, including ECOWAS, IGAD, SADC, and several other regional bodies. He has a long history or a long career as a WHO expert in TB HIV, supporting the rational use of medications in the region. And lastly, in brief, Henry is lectured or taught in the areas of global health, in human and financial resources, in HIV management, medicine regulation, medication utilization and quality assurance, in clinical trials, in pharmacovigilance, in program design and program implementation. So he's a world leader in pharmaceutical and medicine regulation, and we are privileged to have a colleague of such high repute in the field of pharmacovigilance and the medicine regulation in the African context, speaking to us this afternoon. But I'll leave it to Henry. He can speak a little more about his work. So Henry, please feel free to give us this session, the lecture that you prepared for us this afternoon. And thanks everyone for joining this session. Thank you. Over to you, Henry.
Thank you very much, Prof. Nyasolo. And I also just want to thank Chanel, Shelter, and Hanson for putting all of this together. This is a very important, as soon as the presentation comes up, to make sure that we're on the same page. So today I'm just going to be talking about something which is very, very important. Again, medication access and utilization to improve the quality of life and life expectancy in Africa. If you are in the public health space and you are not improving the quality of life or life expectancy for your clients, for the population, then you may be in the wrong career. And for those of us who are in that career, we need to be doing more, because the indicators and indices in Africa are looking the wrong direction. There's been some work, improvement, but we need to do more. And so if you look at medicines, for example, vaccines are perhaps the biggest public health intervention that we've ever had. With vaccines, without vaccines, about 3 million people will probably be dying a year. So that's a very significant intervention. Most other medications, which we're going to be talking about. So in terms of why are we actually having this presentation, with medicines, it's costing Africa a tremendous amount, and we'll get into that. And if not properly used, it can be very expensive. It can actually endanger health, which is where pharmacovigilance comes into play. But the reason why this topic is brought about this time is because for the last several years, for the last 3 years, a lot of students that consult me and want to do public health research, either as a master's thesis or PhD, they're focusing on COVID. And I just want to say COVID, as much as it disrupted the world economy and ecosystem, 266,000 people died in Africa because of COVID, 266 over 3 years span. I just want to make sure that you can keep it on your radar. 500,000 people die on this continent every year because of counterfeit medicines. That's almost double the number. Both numbers are underreported because we don't have proper surveillance systems. And so this presentation is meant to focus the students, the researchers, and anybody who's interested in doing theses that would ask me the question, what can I be researching on? There's plenty of things that we should be researching on because we've made it the new normal. It's endemic. It's actually hyper-endemic. A lot of the things that I'm going to be talking to you today about. So let's just quickly run through. I'm going to do a general orientation of the terminologies that we're going to use. I'm going to talk about what medicines have changed, the dynamics for the last century, and the disease status quo and medication use on the continent, some of the risk drivers, medicine regulation, and I will talk about the implementation science, and I want you to listen to that carefully, using the example of Zambia. And I have a lot of colleagues on Zambia that have joined us. And then how can the African academia be able to play a role in all of this? So in the working definition for this presentation, quality of life. Quality of life is very subjective. Depends on your culture, on your personal values. But what we can agree on, which is universal, is that the absence of disease cuts across. Access to healthcare cuts across. Same with life expectancy, which is a statistical measure to estimate the average number of years that a person can expect to live. All of that, universally, we agree that your health, the environment, and the socioeconomic status is very important for your quality of life. And medication utilization, we'll be coming to understand that medications are very, very important at the cornerstone of healthcare, besides the healthcare infrastructure. So medication utilization comes from when it is prescribed, transcribed, when it is dispensed, administered, and monitored. All of these things, there are 5 levels of activities. If you miss on one, you will not have the optimal outcome that we expect. And these 5 have severe problems on the continent. And so we're going to talk about some of them. So medication access. WHO has an elaborate definition of medication access, which is talking about a well-functioning healthcare system that ensures that there's access to essential medical products, vaccines, and technologies. But the definition that I like to use is a practical definition by the UN Development Group in 2003. It is saying at least 20 essential medicines that have been recommended by WHO have to be available at all times. And the patient has to not walk more than an hour to access these medications. That's very practical. That's the one that I use very often. So here are some interventions that I'm beginning to make sure that our researchers begin to familiarize themselves with. Pharmacoepidemiology basically talks about epidemiology and pharmacology. How are the drugs used in our population? Now you get to understand that when a medicine gets approved, that is in a controlled setting, but in real life, how do these medicines actually work in our population, given the challenges that we have of expertise and the framework? So that's very important. Pharmacovigilance is the fact that every medicine, including traditional medicines, including those that a lot of people call natural medicines that don't have side effects, There is no such thing existing. All medicines have side effects, and it's very critical for us to be able to do that. But that takes us into the next level, which is pharmacoeconomics. Pharmacoeconomics is you looking at the cost benefit. Not all cheap medications are better, and that's where we actually criticize the World Health Organization for their essential drug list. They put out the most affordable medicines, and we're making the argument that some medicines may be expensive, but they end up being cheaper because they have less side effects, less admission into the hospital because the medicine didn't work very well. And then pharmacogenomics. Pharmacogenetics is going to be a new area that if you've never heard about it, pay attention to it. We are now beginning to understand that there are medicines that have been used in the world for a long time. We now see that some of them work better in Black people than they work in whites. And so in the next 30 years, you'll probably be moving around with your genetic code, with your genome, because medicines are going to be prescribed based on that. And in the different region where you live, like some of the medicines, even in Africa, people who live around the Mediterranean, the doses are supposed to be different from those that live in sub-Saharan Africa. So let's talk about the kind of research and implementation science that I'm talking about. A lot of students, a lot of researchers want to focus on new research, which there's nothing wrong. We encourage them to do clinical trials, for example, if they can. They're generally very expensive. The infrastructure that is needed is generally a little more expensive. But implementation science. So in research, you come up with a new approach, something new, just like clinical trials. Clinical trials is going to tell you we have a new drug that works differently and works on this disease. Implementation science would be the one to now take the drug and say, how does this drug work? So implementation science looks at scaling it up, sustainability, and when it comes to medication, optimization. Optimization of the medication tells you how best to use the medicine in your own setting. So that's very critical. And if you take, for example, HIV medications, in the US, there are about 32 of them that are registered. In most African countries, it's only about 7 to 9 of them. And when that happens, if you exhaust your 9 medications for HIV in Africa, then there's nothing else. You go on to palliative care. But in the US, they have various permutations and combinations that they can use. So that's what we call optimization. So optimization is what may be creating a lot of havoc for us on the continent. So that's just a definition which we use for PEPFAR. We're mentioning PEPFAR because the US is the most, has produced the single highest amount of funding to support one disease. They're spending over $120 billion so far for HIV/AIDS, and we've had significant results because implementation science is what we're applying, and that's what we need to do a lot more on this continent for all disease states. So how have medicines actually changed the world, the world over? So let's look at this. Right at the bottom there, it's telling you that according to WHO, life expectancy in Africa has increased by 10 years between 2000 and 2019. Remember, in the early 2000s, life expectancy in Africa was about 40-something years in most of the countries. And if you can think about it, Japan has a life expectancy of 84 years. So if you live in Africa, you're going to die 30 years sooner than somebody who lives in Japan. That's what all of this means. But we're seeing that medications have played a very dramatic role. The vaccines that we've spoken about, we have smallpox that has been eradicated, polio for the most part, except in countries like Pakistan and Afghanistan. We have HIV/AIDS that used to be a death sentence. That's why life expectancy in the 2000s and early and late 1990s was 40-something years in most of the African countries. We've seen how ARVs have worked, but they're surprised that a lot of funding, a lot of infrastructure, and a lot of human resources and innovation has come into it. And that's what we need to continue to do as Africans, and especially the academic environment. So this is again just showing you that between 1917 and 1991, because of medications, it added about 11,200 aggregate years of life to the US population. That's a complicated calculation, but you just need to be able to understand that medications have done a significant improvement, contribution to the life expectancy generally. So this is also just telling you about studies that have been done, very predictable, what medicines are going to do to diseases like coronary heart disease, to breast cancer, lung cancer. But is Africa benefiting from it? It's going to be the next slide the next set of slides that we're talking about. So research and development, everything is lagging on the continent. Well, probably because of the cost, the infrastructure, the expertise, and talking about expertise. It's a different lecture that I give. The brain drain that we have on this continent is significant. As most of you would know, there are more Malawian doctors in the UK than you find in Malawi, more Ghanaian nurses in the UK than you find in Ghana, and about 9,000 medical doctors left from Nigeria to either the US or to the UK in a space of about 3 years. And the other thing is, which is new information that is coming out, Nigeria alone, just using that example, is spending about $1.2 billion traveling abroad for healthcare. $1.2 billion a year that Nigeria spends just by traveling abroad for healthcare. So keep that number in mind. In Africa, we are having a situation where in some countries you could have up to 45 to 60% of the health budget that is being spent on pharmaceuticals. And that's because we import over 90%, depending on the study that you read, over 90% of our pharmaceuticals, of the medicines that we use are imported. And all of you know, because you import clothes, you import food, that whenever you import, it's very expensive. And so that's very, very expensive for a continent that is already struggling. We're currently importing about $14 billion of medicines. And the reason is because of the third bullet. We only have 375 manufacturing companies on this continent, and mostly manufacturing generic products, which means these are not innovative products. But compare that to 10,500 manufacturing companies in India. And so you would understand why. If it comes to vaccines that are very critical, we're actually importing about 99% of vaccines in Africa. And this is a huge market that, when properly developed, we should be able to create 16 million jobs. So that's what everybody is looking forward to. Now, why is it so difficult to come up with medicines and pharmaceutical companies? The infrastructure is a little bit expensive, not a little bit, it's quite expensive. It takes about 10 years to bring a new drug to the market. And how much does it cost? It costs about $1 billion to $1.2 billion to do that. So if you look at the heading, there's something written there, neglected diseases, which is a terminology that I hate. Neglected diseases is because since our drugs are developed either in the US or in Europe, if you have a disease in Africa like sleeping sickness, like elephantiasis, river blindness, these diseases don't attract the manufacturers to manufacture. So when you have this neglected disease in Africa, which is something that we must focus on, and in order to change this terminology called neglected disease, neglected by who? We should not be calling our diseases and our people to be neglected. What we should do is the academia and the research organizations should get together and make sure that we don't call them neglected. They are neglected because the big pharma don't want to develop. And there are many of those diseases in Africa that we call them neglected. In the US, they call them not neglected, is orphan. Orphan disease in the US are the diseases that would infect or affect about less than 200,000 people. So the government of the US gives tax benefits for the manufacturers to manufacture. So they don't have a problem. They came up with a solution. We need to come up with a solution for neglected diseases. So this is what happens leading to pharmacovigilance when a clinical trial is being conducted. It's conducted on healthy people like you see on the top. But when the drug becomes available, it's used by all the adults that you see in the bottom. And that's where implementation science comes into play. How does a drug that was used in the person above now become used in any of the person below? You can see somebody an alcoholic, you can see somebody is overweight, you can see even a pregnant woman, and even with the child, children don't get enrolled in studies. We just extrapolate the dose. So you need to monitor them carefully. And that's why we have this graph, which is my favorite graph whenever I present on pharmacovigilance. This graph is telling you that the airline industry is very careful because they know that if an accident happens in the air, everybody is going to die. And so since 1979, airline accidents have been going down. You can see the last line that is drawing on underneath. It's talking about airline industries. So they take care of themselves. That's why you see pilots are well taken care of, where they don't ask them to work overtime and things like that. But look at the top line, is medication. That's the number of people that are dying from medication by either way, including counterfeit. So it keeps going up for over the years. So as public health and healthcare workers, we need to double up. You can only imagine what is happening on the continent in Africa. So because of that, access to medicines becomes very challenging in Africa. It's the two things that we're trying to do now, and everybody is trying to put their hands together, is we need to buy intelligently because we're importing. So there's something called pool procurement. If you take 10 African countries, 15, and ask them to buy penicillin together, you can actually reduce the price by 40%, 50%. But the challenge is, how do you get 10 sovereign African states to work together? That's what is very challenging. And then how do you strengthen medicine regulation? Because the bureaucracy and the lack of expertise and funding is actually sometimes an impediment. And then local manufacturing is what we need to get the private sector involved. So you see procurement, storage, distribution, and manufacturing. All of these things are going to change the dynamics. But where do you get the funding from to finance it? It needs to come in order to be sustainable. Our governments have to be involved, private sector needs to be involved, and other development partners. So I didn't tell you that usually when I give a lecture, there must be a quiz for me to be satisfied. So at the end of this lecture, there's going to be a quiz. So get a pen and paper ready. So let's just run through the disease burden and then some of the challenges that we have with medications. Look at malaria, for example. Malaria, 94% of malaria is in Africa. And I just want you to pay attention on 580,000 Africans die of malaria on a yearly basis. Again, I'm telling my students who come to me that you can't all be researching COVID. COVID was 266,000 people who died in 3 years. And we know the disruption, but malaria also disrupts on this continent very significantly. And then you can look at TB, for example. Again, although TB is, Africa is second, in Asia you have first in terms of regions where you have prevalence of TB. However, you would see that in TB, 500,000 people die of TB in a year in Africa. If you look at under 5 mortality, 2020, 844 children under 5, 844,000 in Nigeria died. And you can see the other countries that are there. Most of them are African countries, a couple of Asian countries. This is the map that we're sitting with. HIV, we know that 65 to 70% of the HIV in the world is in Africa. And so 630,000 Africans die a year from HIV. So those are the challenges that we have. And I'm just going through this because this presentation is supposed to be in 40 minutes, so we can give some time for interaction. Non-communicable diseases are becoming a problem on the continent. People are living longer, even with HIV, which means non-communicable diseases. Africa, a lot of cancer diagnosis and a lot of people dying of cancer because if somebody has breast cancer, the overall survival, 5-year overall survival in Europe is about 82%. In Africa is about 46%. The single reason is, the most important reason is that the state-of-the-art medications are not available, they're not affordable. There's something called catastrophic health expenditure. There are some households that are spending 70% of their money on treating one cancer disease, and that's unacceptable, and that's not going to improve anybody's quality of life. So diabetes, again, you would see that these numbers are staggering, but according to WHO, 36% of countries in Africa have essential medicines. Only 36% of countries in Africa have essential medicines for chronic diabetes. 36%. Again, this is not going to contribute to anybody's quality of life or life expectancy, which is what this presentation today is all about. Hypertension, you're going to see that it's the same thing. In terms of hypertension, which is non-communicable, it's on the rise. Now Africa is becoming number one. We have a population of 1.4 billion people. We're becoming number one. Again, a lot of things can contribute to it, but part of it is the fact that a major part of it, we don't have the medications for control and for treatment. So medication challenges, I'll just run through this one for you to get an understanding of it. More than 50 to 60% of African countries lack access to essential medicines. That's very pathetic. Essential medicines are already the medicines that are supposed to be cost-effective, cheaper, and affordable, but only more than 50 to 60% of these countries lack access to a consistent supply of this medication. And then if you look at, I was part of this discussion at the UNECA, at the Economic Commission, the UN Economic Commission for Africa. They were focusing on maternal and child health. And so some of the data that they collected, you could see that up to 70% of medicines available to save lives of young mothers and are substandard. That means some of them are pure counterfeit, 100% counterfeit. But you can see in 2017, an estimated 196,000 women died from pregnancy-related causes. 196,000. If this was in the US, it would be an uproar. And so you would see where there's an uproar in the US because of people dying of medication errors. So if you look at, this is a study that was conducted by WHO looking at the different African countries, how they regulate medicines. And you find out that we're supposed to be regulating medicines about the same. The change, I mean, the differences are very, very, very small within the African context. But if you look at issues like medication registration, licensing, and inspection, they were very different in the different African countries, which makes it very difficult. And we're having a mobile population. The borders are very porous. We ought to be having a harmonized medicine regulation, which is what a lot of people have been working on. We've made some strides, but still very far away off the mark. And that's something that we need to be engaging in. So this is a creation that I came up with to let people, when I do the presentation, especially to regulators, that the fact that you have registered a medicine does not mean that you will have optimal output. So I've been pushing and suggesting the fact that we should start using public health indicators to measure how well medicine regulation is working in each country, because they've not been doing that. So we need to be able to use that to say, did you register the right medicine? Is it working well? Because if it's not, then you should be also accountable to that whole system. So let's look at some of the other challenges with medications. You would see that 42% of all counterfeit in the world is used in Africa, which means if you're making fake medicine anywhere in the world, your market is Africa. Why is it so? The borders are porous, the systems are not very transparent, you don't have the expertise to do the inspection. Then why are we surprised that the life expectancy is very low? Why are we surprised that the quality of life is very low? And again, nobody's going to change this for us. We can talk about this for the next 50 years. We need to start becoming creative. There was a creativity that was done during HIV/AIDS, which is what they call task shifting. It was found out that we don't have enough doctors, we don't have enough nurses. There was no need to cry about it because it's impossible to get enough doctors and nurses on this continent because it's a human rights thing. They keep leaving. And so what they did was task shifting, which means nurses were now able to do some of the work that doctors were initially doing. And like in pharmacy, for example, a pharmacist should not be dispensing. You should have a pharmacy technician while the pharmacist is there to give advice and counsel the patient. These are the kind of innovations that we need to come up with. But look at what is happening. We've already said 42% of counterfeit in the world is in Africa. But if you look at this picture, America is the one, North America is the one that is very stringent about it. They've had pharmaceutical crime incidents about 1,750. This is, I think, in 1 year. And in Africa, it's only 142, which means we're not even doing anything that much to be able to curb on this. Medication errors. In the US, 96,000 people die because of medication errors. You should see how it's a big deal in the US. All the hospitals in the US are asked to do medication error reduction monitoring. If they come to inspect your hospital and you don't have that by the Joint Commission, you have a citation that is very, very critical, and your news will go all over that you are not taking medication errors seriously. Only 98,000 deaths, although they said it's probably also underreported. WHO estimates that 2 million people globally die annually due to ADRs and medication errors. And I bet you majority of them are going to be on this continent. Again, that inversely affects quality of life and life expectancy. Look at adverse drug reactions, 100,000 emergency hospital admissions in the US. And your question in your mind is very obvious. Why are we always seeing US data? Because they do implementation science and research, which is what our academic institutions are encouraged to do. We don't have data in most of the African countries, which is something that we should be doing. Practical data that affects the livelihood of our people on the continent. Non-adherence, it's a major thing. The US is spending $300 billion on non-adherence, which means you prescribe, I don't know how many of you know that if somebody has chronic medication, after 1 year, they never take the medicines very correctly. And so they may end up in the emergency room. All of this is calculated in the $300 billion. So let's talk about what is happening in Zambia. And I think my Zambian colleagues on the line are very familiar with this and very happy. In Zambia, through Howard University that I work, we are supporting 30 high-level, high-volume hospitals in Zambia. So we follow a cohort of 140,000 patients. I think it's the single cohort that I know of that we are following. 64% of them are female, as expected, 36% of them are male, and I'm the PI for that project alongside Dr. Maxwell. So initiating somebody on treatment is not that challenging. You can now have protocols that you give them one tablet and they go home. This is what you need to monitor. You need to make sure that there's rational medication use. Did you check the kidney? Did you check the liver before you gave the medicine? You need to make sure that the patients are retained in care, which is a challenge. Even here in South Africa, retention is lower than it should be. So in our program, retention is very high. And then adherence, people get tired of taking medication. What are the strategies that you encourage them? Now, before the linkage in care is people get tested everywhere on the stadium, at the petrol stations. How do you make sure that you follow them up? If you do all of these things and monitor the adverse drug reactions, you're guaranteed to have a good quality of life on HIV patients. That's why we see our HIV patients, particularly in this cohort, are living very well. We can guarantee that. Now, what we did when we came to look at the 30 facilities, we did a baseline. We saw that people were waiting online for an average of 4 hours. Some people waited for up to 8 hours. Imagine somebody who sells in the market, waiting in line for 8 hours just to get medications, get a blood drawn. Retention was only 60%, and the viral load was also 60%. And so there was no adverse drug reaction, there was shortage of healthcare. And so these are the results that we achieved. And I'm going very fast because it's soon coming to time that I can give you some time to be able to ask some questions or comments. Now, this is a typical site in Zambia that we're working at. What you see in red is how patients normally would come to the facility. From the data that we collected through the implementation science, we saw that you have to queue at red number 1, red number 2, red number 3, red number 4. And by the time you finish, and we're talking about HIV, most average HIV patient is either somebody who doesn't have a job or somebody who's selling in the market or a truck driver, and you're asking them to spend 8 hours. Most of them just don't come. And that's where the retention is very low. So when we did that, we consolidated all of these services in one site, did a lot of training. And so this is a result of it. You could see from the graph there that nobody spends more than 50 minutes at the facility. This is from 8 hours. And at best, we have people who spend 30 minutes and they get a full service. They've been extremely happy with this intervention. And this is the kind of research and implementation science that I think we should be very practical in making sure that we address our population. 98% is the adherence and the retention that we have, which means our patients stay with us 98%. We know where they are, get contact with them, they come back to the facility, and I'm going very fast, otherwise I'll be able to explain to you what we do exactly to retain 98%. If you go to most facilities in Africa, most of them retention is about 60, 70% at best, maybe 80%. We're very proud to say in this cohort of 140,000, our retention, even after 12 months, our retention after 6 months is usually about 99%. So we're doing exceptionally well. And adverse drug reactions, we contribute to 95% of the adverse drug reactions that are reported in the country Zambia, and through this program. And we're able to prevent where we can prevent adverse drug reactions, manage those that we can manage. If you initiate somebody on treatment, it means you expect that their viral load, the amount of virus in the blood, should be undetectable. And we have a 99% of that. You don't find that in many facilities. We work very hard. If your retention is good, your adherence is good, they're taking the medications, your pharmacovigilance is in place, this is what you're going to get. You're going to get 99% of viral load suppression. And what's going to happen to the quality of life? It goes without saying. Quality of life is going to be good. The patients are very, very happy with us, and life expectancy, we expect it to be higher. And this is just talking to you about what we've introduced in pharmacovigilance. It's an innovation. Patients live in their communities at home, not at the hospital. Most of the pharmacovigilance programs globally, and especially in Africa, they wait for the patient at the facility. Most patients come to the facility, they want to hurry up back. So this is community-based pharmacovigilance, and I will not bore you to go through it, but that's how come we report 95% of what is reported in Zambia nationally comes from this program, because we're very creative, we're very innovative. We reach out to the people in their communities. Our community health workers, we've trained them, they know what questions to ask, and we're able to collect the data that we collect. And so, in conclusion, I want to talk about, we always talk about, this is a pandemic, hyper-pandemic, that we've just made it the new normal. Because 266,000 patients died, we were up in arms. We should, because one person that dies is very important. But we have so many conditions on this continent that hundreds of thousands of people are dying. So African solution for African problems is a slogan that we use. What does that mean? Agenda 2063 says the Africa that we want. What kind of Africa do we want? And what role do we have for traditional medicine? I know that there are people who are on the line that are saying, I haven't spoken about it. It's a whole lecture on its own. There's a role for traditional medicine. The only problem with traditional medicine is that we've not been able to quantify. Some of them have a cultural and spiritual component. How do we begin to package all of that so that it can be economically empowering to Africa? WHO has recognized that traditional medicine must be integrated in healthcare in Africa, but how do we do that? So that's the challenge that we have, and this is a lecture for another day. How can academia be a major player in this? Academia is where researchers come from. This is where people write theses, people think out of the box. We expect them to begin to solve this problem. So here's the quiz that I have for you, just to see how many of you were listening. Now let's do the math together on these few diseases and conditions. How many people died of COVID-19 in Africa in the 3 to 4 years? Right? How many people die of malaria in Africa yearly? How many people die of TB in Africa in a year? How many people die in Africa from counterfeit medicines every year? How many people die of AIDS-related illness in Africa every year? And averagely, what percentage of health budget is spent on pharmaceuticals? I may have said up to 45–60%. I'll give you the answer to this. Most countries would hover around 25 to 30%. That's very high. The US spends 9%, and every year is debated during presidential campaigns and because they think it's too high. They're thinking that ideally it should come down to about 5 to 7%. But in Africa, I think one of the best is South Africa, maybe hovering around 15%. Most of the African countries, 30%, but you do have countries that 45 to 60%. If you spend that amount of money only on importing medications, look at what is left for you to intervene on other health So this is going to affect. So lastly, neglected disease in Africa, which I spoke about, compared to orphan disease in the US. How many pharmaceutical manufacturing companies in Africa compared to India? We must collectively change this narrative, and academia must step up, and the researchers. So this is just talking about we need to harmonize in Africa. A lot of African countries, we're still suffering from the post-colonial days. Everybody's holding tight onto sovereignty. This is a sovereign country. We need to break down some of these borders, particularly so that we can have harmonized regulation, so that if you have one clearinghouse, or if there's counterfeit in Gambia, we should send a warning signal to everybody. All the African countries say this product is not good. But we don't do that, and we end up with 500,000 people that are dead on the continent because of counterfeit medicine. And by the way, that is way underreported. And so these are some suggested areas of research that I have. You can do research in the area of medicine regulation, medicine utilization, medicine monitoring, things like pharmacogenomics. We can begin to gather our own data where you're comparatively. How do these drugs work in Caucasians compared to blacks? There are many drugs that were warfarin, which is a blood thinner, which a lot of black people are on. It works differently in black people than it works in whites. So this is because of the genes that we have. And so these are a number of things that we have to be looking at. I'll be able to share this presentation if you want, but here's my last slide, I guess. So when you go to the restaurant and you're eating your steak, I see a lot of you cut pork. You cut the fat out of it because you want the lean meat to be able to eat. That's how healthcare, especially in Africa, looks like. So I'm showing you areas that have a lot of pork. Non-adherence that we saw, rational non-adherence just basically means we're spending too much money and patients are not adhering to treatment. They end up in the hospital, they end up dying, they have side effects because they double up on their doses. Rational medication use is something that we need to even teach our doctors who prescribe the medication. When the doctors, some of them leave school, when you tell them now you have 3 bacteria, they will use 3 antibiotics. They will not be able to understand that I can use 1 antibiotic that will cover the 3 bacteria. Lack and inadequate pharmacovigilance. This is the worst continent in documenting adverse drug reactions. We need to change that narrative. Antibiotic stewardship. I've spoken about the fact that we don't have the luxury. We have just few antibiotics here. If we don't optimize, we're gonna get to a point where we have bacteria, we have infections that no antibiotic that we have is responding to it. And then you have to do special importation, which is very, very costly for the country. Dynamic formulary management. We need to start finding out which drugs should we get in, even those that are a little bit more expensive, the cost, the pharmacoeconomics that I spoke about. And then healthcare worker competency. Number 1, I've spoken about the fact that in the next 50 years, you will not get enough doctors, enough nurses, or enough pharmacists on this continent. So you better be looking for an alternative solution. How are we going to accommodate the few that are left here? On that note, sorry that I had to run very fast. I was trying to meet up so that I can turn it over to Prof. Nyasolo and Sunel. Thank you all very much, but I'm available. You can contact me through both of them if you have any questions. Thank you.
Wonderful, wonderful, wonderful. Thank you very much, Dr. Henry. Yes, yeah. Hand of applause. Thank you, thank you. This was fantastic. Broad, exciting, very detailed enlightenment in this area of pharmaceutical regulations. So, colleagues, if there are questions to ask, Dr. Henry is here to respond to. Let me just check if there are questions on the chat, if there are any questions on the chat. Otherwise, you can go ahead and ask if you have any points. Dr. Mida, you can go ahead.
Yes, Dr. Fomundam, thank you for that wonderful presentation. Quick question: what is the future of pharmacovigilance in Africa? What is the stake of regulation in harmonizing a strong regulatory mechanism that can enhance quality of life? Thank you.
All right. You want me to answer that quickly? Those are two very loaded questions. Pharmacovigilance, it's beginning to surface. It was almost at zero on this continent. Sensitization was not well done. The continent and the development partners were actually interested in getting the medications in Africa because they said the medicines were not available, but the quality of health was being neglected. So now you're getting to a point where we're beginning to train people on pharmacovigilance, which is an area that I've worked on for many, many years. It's beginning to sensitize people. And we want to get to a point where we can start reporting across borders. But the laws, the legislations are very prohibitive. So if something is happening in South Africa, you just cannot share it across the border because South Africa is a sovereign state, Botswana is a sovereign state. We're trying to see how we can harmonize all of those things, which also comes to the question you're asking about medicine regulation. Medicine regulation, they've come up with what they call the model law, was put together by AUDA NEPA, which would help the countries to be able to remove some of the prohibitive laws that they had, which said you could not share anything across the border. So that model law has to be domesticated by each country, which means it has to go through parliament. And anything that goes through parliament on this continent takes forever.
Wonderful. Thank you. Thank you. Any questions? There's a comment by Turisire. She's excited with this subject and she thinks she can use this for her master's thesis. So Turisire, feel free. You are in Pretoria. Based on what you have said here, maybe Prof. Henry also is working in Pretoria, so you can easily link up. And that's the purpose of these forums, really, to connect faculty to postgraduate students for training. Let's hear from Frunche. Frunche, you can go ahead.
Thank you, Prof. And thank you, Dr. Fomundam, for a very enlightening presentation. I'm especially impressed with the work that you're doing in Zambia. It's absolutely amazing on HIV, so well done there. I have a question, and the basis of that is the initial statistics that you shared on the non-communicable diseases. And I can understand the case of infectious diseases that exist in Africa because of the, I suppose, the chronic underinvestment in the infrastructure. But on the communicable diseases, you focused quite a lot on, I suppose, the disease management, the curing of the medicines and that. It sounds like we're following the same trend as in the US, where, frankly, in my opinion, this hasn't worked in trying to actually cure non-communicable diseases. Should we in Africa not be approaching it differently in terms of, by the way, I'm a food scientist, so I'm approaching it very, very differently. Should we not be looking at preventative measures, which really we know that there's a link between non-communicable diseases and nutrition, lifestyle? So should we not also be encouraging the investment in this area rather than pushing investment into pharma?
Mm-hmm. So that's a very brilliant question. And we need to be able to approach from both ends. And I remember in the earlier days working on HIV, people were asking, should we be investing in HIV prevention or investing in HIV treatment? The same question that you're asking, that shouldn't we be investing more in the disease prevention rather than treatment? Now, if the way the world functions, we're going to definitely have people that will continue to have this non-communicable diseases. So that's the area that I was focusing on, those that have had the non-communicable diseases. But if we had a basket of funding, I probably would be saying, let's split it up, make sure that we prevent, and at the same time, we should not neglect those that are already having the ailment or diseases. So yes, I think that's what a lot of African countries are doing, but not nearly enough. Actually, they're not handling both of them very well. Both of them are very, very important. Those that are already having, we should make sure that they're getting the best treatment. And those that do not have, we should also be investing physical exercises, the diet, and things like that, which is what we should be investing on. But we're not doing both of them very well. And I think this is where the implementation science research should be coming on board to be able to help us. A lot of times we're waiting for development partners from abroad to be able to give us the funds. And I'm saying University of Stellenbosch, for example, you need to get a number of things working and making sure that you're engaging the government and making sure that some of these interventions are in place. Thank you very much.
Thank you, thank you, thank you. There's a question here from, let me just ask this question. Great presentation, yeah, maybe you asked already. Andrew Malanga. You can ask a question.
Yes, thank you very much. Thank you, Dr. Fomundam, for the great presentation. I was just wanted to know, in your opinion, considering that we import a lot of medicines from outside the continent, what are the major barriers to manufacturing of pharmaceuticals in the country, in the continent? Thank you.
Thank you, Dr. Maranga. The biggest barrier that we have is the funding. Right now, they're encouraging the private sector to be able to fund. For you to set up a properly functioning manufacturing plant, it's several $million. So that's why you see the 375 manufacturing houses that you have on this continent, perhaps 90% of them or more is generics, because to do generics is a lot easier. To do generics, a lot of them order the raw ingredients from China or from India, and then maybe put it into capsules or compress it into tablets. We're looking at local manufacturing in a way that the UNECA has come up with a definition. Local manufacturing would benefit from the Africa Continental Free Trade Area, where you don't pay tariffs and when it moves across the border. That's something that is gradually being embraced. It would mean 60% of your active ingredients should be developed on the continent, which means most of them come from plants, from things you will need to grow that and things like that. So that's an expensive process, but one that would be sustainable. So the single answer to your question is funding, and then second to that will be the expertise. But I'm sure that if the funding is available, we will have to start attracting expertise. In my work, I'm beginning to encourage that we use Africans in the diaspora. And there are lots of Africans in the diaspora who want to give back to their countries. So we should start getting them to come back and participate in these processes. Otherwise, the answer to that question is funding and expertise.
Thank you, thank you. There's a question by Pepla. Pepla, you can, I can't get the full name, but yeah, you can go ahead. Yeah, Pepla. Unmute yourself, unmute. Okay, maybe as you are unmuting, let's get another question. There is a question on the chat here.
Okay.
Okay. You can go ahead.
Yes. Well, this is a brilliant exposition by Fomundam. He will never let you down. The perennial problem that I have on such discussion is the negligence of veterinary medicine. We know that a lot of diseases are spread by animals, zoonotics, and we don't seem to be addressing these issues in respect of veterinary medicine and how we can really, control the impact of the spread of diseases to human beings. And this is a question that I always pose to Henry, and he doesn't seem to be getting the desired attention. And my question is, why not?
Thank you.
Yeah.
Go ahead, Doctor.
So, Mr. Pepra is calling from Ghana. The issue with that is not lack of the will or approach, is because we're still, generally speaking, struggling with human medicines to control it. you're correct that we need to do both. And there are a couple of regulatory authorities in Africa that are doing both. Very few, maybe about 15% of them do both human and veterinary medicine. Like you're saying, veterinary is very, very important. A lot of the diseases that we have, Ebola, COVID, they come from animals. Although those are not the animals, these are not domestic animals. These diseases come, some of them from bats and from other animals. If we had strengthened the veterinary regulatory component, maybe they'll be able to pick up some of these a lot faster. So it's again a matter of lack of funding and lack of infrastructure. The will is there, but we need to push it up to make sure that people begin to fund it. And there's too much dependence on donors. So if this discussion can happen at the level of the African Union, that would be good. Remember, in the year 2001, the Abuja Declaration said all the ministers of health gathered in Abuja and signed that they were going to contribute 15% of the GDP to health. None of them is at that level. At best, most of them are hovering around 5%. So if they could have done that, then that would give us time to be able to start getting into all the veterinary because of zoonosis. And part of the other zoonotic interference that we have is that people, but again, not really in Africa, a lot of people are having exotic pets like snakes, lizards, and things like that. So we begin to get mutation from those animals, which is a challenge. Not a major problem in Africa. The major problem in Africa, which again you would know that HIV, Ebola have all been attributed to the Congo Basin because we were traditionally hunters. We interact with the animals, and so there's mutation of the viruses and things like that. That's a lecture for another day and a debate for another day. But it's a good point, and I think it's one that people need to embrace as soon as the funding is available.
Thank you, thank you. There are two, I think, last two questions. Doris, and thereafter Dr. Msonda Malumbo. So start with Doris and then Marumbo. You can go ahead.
My hand is up also. Thank you.
Okay, let's see if we can catch on time. So I can maybe ask the questions because they are here. So my question is, are there any reliance measures that you have put in place in terms of medicine regulation? That is from Doris. And then I can ask for Dr. Malumbo, what are some of the strategies that can be used to ensure communities understand the importance of proper medication use and ways of identifying substandard medication? Supplementary, how can we tackle misinformation and myths about medications in rural areas? I think attend to those questions.
Sure. So the first question is somebody who's very sophisticated asking about reliance. Reliance is part of convergence in medicine regulation, where you share information with a regulatory authority that you think is more advanced, you think it has the expertise. Like on this continent, it'll probably be a country like South Africa or Egypt that have the resources and would have you can rely on. And again, this comes down to the bureaucracy that we're talking about. It comes down to the sovereignty of exchanging information. Otherwise, there's discussion around reliance on this continent, which means you can pick out a number of the regulatory authority and you can sign an agreement with them so that if they have the expertise, they can review a medicine for you, and then you just take the information that they've reviewed and you can apply it yourself to your own country. However, to do that is not as easy as we say because of this issue of sovereignty. You have to have a lot of discussions at the level of parliament and to make sure that there's an agreement to that effect. But the discussions are going on, and there are a couple of reliance, and we will need to rely not only on medication, but also the laboratory control. So to build a quality control lab is also very, very expensive. So there are a couple of them on the continent, and people have to rely on them from different countries. So reliance is going on. Malumbo's question is on identifying counterfeit in the community. Now, you have to understand that because of the lack of resources, that's what even pushes everybody to counterfeit. So if you come with a medication and say, I have this medication is half the price that you can buy in an authentic pharmacy, because a lot of people are, they don't have the financial resources. They tend to listen to you. But the solution to that is what we're introducing, that we're going to start doing in Zambia, is community medication literacy, where we can have groups of people in the community. We sit them down and say, you'll be doing more harm to yourself when you buy these medications that are sold by hawkers. Because the medication by hawkers come from India, from Pakistan. They came through through borders from other countries, and so it causes more harm than good. If you are able to do that and show some pictures, it will be very good. Like we said, 500,000 people on this continent die a year because of counterfeit. It's way underreported. In my view, it's probably 3 times that number. Thank you.
Thank you very much. Marumbo, you have several questions, but please feel free to engage with Prof. Fomundam. We've run out of time, but Francis, you've been hanging for some time. It's a short question, so please go ahead. Short, and that's the last question.
Thank you. I've just written the capsules on the chart. These capsules have just been inaugurated recently in Tanzania.
Okay.
For the BPH, the prevention and treatment of BPH. Now, for such developments, what can we do as we people who are dealing with these pharmacokinetics, and how can Prof. Fomundam include such researchers in terms of the work that he's doing? Thank you.
Yeah. Prof. Hira, that's a good question. And I didn't talk about that because I would have liked to talk about developments that take place on this continent. The problem is we have to make sure that we do intellectual property, which is what a lot of people are afraid of. Make sure that there's intellectual property that will protect whoever comes up with the innovation. That's number one. Number two, we need to make sure that your country is aligned to be able to get you with some researchers, mainstream researchers. And because as individuals, particularly if you don't have the resources, you're not going to be able to do it. So each African country, which is something I've given a lot of TV interviews on, is to make sure that the country should be available to do a call-up of people who are innovative, traditional healers, who have something that you can quantify. Because I gave an interview on the TV to say, if treatment for COVID was to come from an African village, people will accept it because people were dying. Look at how many people were dying in Europe. It doesn't matter where treatment comes from, but you need to quantify it. You need to show proof that it works. And you need to do what a lot of people do. It should be marketable. When you come up with a product, which is what some people did here in South Africa, I have a product, but I also have to lay my hands on your head. How are you going to do that? Are you going to ask the people from Europe to all come to South Africa so they can bring your medicine and then you lay your hand on their heads? So these are the things. So to answer your question, is engaging the Ministry of Health in Tanzania, making sure that the product, number one, is protected. You have intellectual property on it. Number two, the government will be able to link you up maybe with some researchers in South Africa or researchers in anywhere that are willing to partner, so that when the results come out, it should be global. And if it's global and it's well accepted, then that person and the whole village will be very economically empowered.
Thank you very much. Unfortunately, all good things have to come to an end. The discussion was so exciting. I wish we continued, but we've run out of time that was allocated for this activity. Once again, thanks very much, Prof. Henry, for this robust insights and this wonderful discussion. And thanks everybody who spent their time to actually listen to this talk and contribute and ask questions. I very much would want to say thank you. So once again, thank you everyone, and may you have a blessed afternoon. Thank you.
Thank you.